And we have our next speaker. We're switching the program around a little bit, so Evelyne will go now, and then Paul from Molecule, one of our sponsors, is coming up right after. So let's give Evelyne a warm welcome.
Thank you so much, Morten. All right, no problem. So, welcome everyone, and thank you so much for also giving me the chance to speak about another topic that we are seeing in the clinic. And as yesterday during the Longevity Medicine Day I mentioned, we are trying, at least in some of the academic settings of the hospitals, to really bring longevity medicine into the sick care setting. And the field that I am working with, or in, besides of internal medicine, is oncology. And for the past year or more, I shifted from breast cancer more into pancreatic cancer. So we are seeing really very poor prognosis and people with very interesting pictures of morbidities, and it's a bit easier to study in terms of aging and longevity in this type of cohort. But I would like to extend this topic and present something that we've actually commenced also with Alex and some collaborators from Chicago, the term of ger-oncology. So the mix of healthy longevity and oncology, and how longevity medicine can actually assist us, oncologists, in different parts of our clinical work, in the triage, in the diagnostics, in the predictions, and also in discussions with the patients. But let's start with the content. So I would like to mention once again the healthy longevity medicine definition as a beginning, and then to try to illustrate the difference between ger-oncology, what we are trying to do in ger-oncology, the section or the intersection between longevity medicine and oncology, and geriatric oncology, which by now is really an established field. When I started my training, it was just blossoming and being developed. Now it's really a great discipline with good guidelines and recommendations. And then to present some of the crossroads studies that we have done and give an outlook on the interventional perspectives and education. So for those of you who haven't been here yesterday or didn't listen online yesterday, Healthy Longevity Medicine Society tried to define healthy longevity medicine as a field that is optimizing health span along the lifespan, targeting the age-related processes. And in terms of ger-oncology versus geriatric oncology, we are trying to implement this definition to make a difference with geriatric oncology, but also to show the parts that are similar. So just like geriatrics and gerosciences and healthy longevity definitely are going hands in hand, and we are learning from gerosciences and translating into the healthy population, similar things are happening in oncology, not only on the interventional side. And as you can see here, geriatric oncology, I will start with that, is a defined field. There is a definition. It's a branch of oncology that is targeting elderly patients, 65 plus. Before that, we were speaking about the elderly or the oldest old. You can still find those terms in the literature. That was the definition of 65 plus or 60 plus. Those were the elderly in oncology. And the oldest old were the 70 and 70 plus. Right now it's geriatric oncology, and it's quite defined as 65 plus. Why? Because most of those people who are 65 plus are not included or have not been included for a long time in clinical trials in oncology. So as a clinician, you are always facing the dilemma, how will I decide? And very often, in those countries where a tumor board, like a discussion, interdisciplinary discussion, is not manifested, or where there are so many patients that it's physically impossible to discuss each patient in a disciplinary quorum, it's important to have at least a movement that will include those patients or this population into the clinical trials. Now, ger-oncology is an intersection of longevity medicine and oncology. It's not defined officially. It's something that we are trying to define as exactly this permeation of longevity medicine diagnostic tools and hopefully also interventions, senolytics, xenomorphings, and others into the oncological field. And given the definition and the mission and goals of geriatric oncology, we can follow what could be also the determination of ger-oncology. So just for example, integration of longevity medicine / geriatrics in geriatric oncology, longevity medicine in the decision-making and guidance of the patient, but also in dividing the patients, for example, in the clinical trials to different risk groups based on toxicity, for example, and different dosage groups. Developing and testing and disseminating different diagnostic tools. So we will be talking a little bit about the liquid biopsies that are now also available on the market for patients themselves, and they are using them a lot. How do we integrate them actually in our medical practice in the clinical setting? We moved, there was a shift from so the testing of oncogenes and stratification of the risk of toxicity and survival. About 15 years ago, it just came, as a movement into the breast cancer. Now it's all across at least the solid tumor diagnostics. And last but not least, creation of clear and defined recommendations. In geriatric oncology, for example, it's based on the age, on the chronological age based on the date of birth. Hopefully in ger-oncology, in the intersection with longevity medicine, it will be based on the biological age. That will be based on biological aging clocks that have been developed on cohorts of oncological patients and not on the healthy patients. So the dilemma, again, in oncology is really we know quite well what to do intuitively as oncologists, what to do with an elderly person that is very fit and with an elderly person that is very frail. So there we would go for dose reduction and we'll go to best supportive care, but there's a huge spectrum of people in between that. And how do we decide what would be the best approach for them is still quite undefined. And so in geriatric oncology, as I mentioned before, there are already societies, SIOG, for example, and others that have defined quite well guidance for doctors what to do, not guidelines, but recommendations and guidance. In ger-oncology, we will be facing a little bit of a more advanced problem, because those will not be patients who are already maybe towards, facing to the end of their life, or where we would not be thinking about the toxicities that might arise 20 or 30 years later, such as polyneuropathy or all the other things that might arise from current therapies, even if they are very advanced, but they might really diminish the quality of life for a person later. So how do we deal between, in the spectrum of younger patients, chronologically, but biologically they might be differing a lot. And on top of all that, aging and cancer have or share a lot of pathways. I think it's the discipline that shares most of the pathways of aging and also senescence. So many of the processes in aging, accumulation of DNA damage, and so on, many of the hallmarks of aging are actually intersected with oncology and leading to development of neoplasms that then might develop further. And at the same time, we've heard a lot about the aging population, and it should be probably underlined that aging is the #1 risk factor for cancer, not genetics, not other parts. So in terms of oncology, there was a term that has been developed called competing risks, meaning basically what is the threshold for a patient to respond to a treatment that a younger patient would receive without many complications or toxicities. Since this term is not really measurable yet with objective markers, we still face the problem of over and under treatment. For a long time, even that was not defined. What is an under treatment? What is over treatment? Now there is at least a definition, but it's very intuitive. It's just either giving too much treatment and leading to toxicities, or too little treatment and depriving the person from therapy that might have lead to a better overall survival, or at least disease-free survival, or to lead to an outcome that the patient would actually wish for. So many patients in oncology, they just wish for a good quality of life. So we need to integrate that also into our strategic thinking, rational thinking. Survival is not always what the patient is actually aiming for. And last component into the entire picture of geroncology is, of course, decline, functional decline, which we see in elderly patients, but we also see that basically from the moment that we are going down from path from our age, chronological age of optimal performance, and all of the functions are going down at different pace. Of course, it's extremely individualized, therefore the need of longevity medicine and oncology. But overall, we know that in general, with age, we decline, and not only physical decline is important in oncology, the cognitive decline is extremely important for very simple reasons. The compliance, the fact that many people are lonely or single and aged, so they might not return for another course of chemotherapy. They will forget to take, even if it's on per-oral chemotherapy, radiation, and so on. So cognitive decline is very important, and that's on top of the fact that very often we're still facing the problems of brain fog and fatigue, which is making it harder. So in geriatric oncology, that has now entered public clinics pretty much as a standard, at least in bigger centers, we see that implementing screening tools is extremely beneficial. And finally, we have a good wealth of knowledge and evidence base that it actually is important, and I think I don't have to convince you about that, but what I would like to point out is very often those screening tools are catching things that a clinician, even a very experienced one, will not catch just in a single anamnesis and consultation. So it does make sense to run those tests, and clinicians are usually overburdened and they don't have time. Luckily, there are now tools that have been tested that are very quick, like G8 test, for example, with a very short assessment. The most important part, or the most interesting for us, I think, here is that very often we see a person that might appear very fit, and we just don't run those screenings. But then we proceed with surgery, chemotherapy, right, with anything that would be called as a destabilizing event. And then we see that the frailty or the toxicity or really the decline is happening right there. So to catch this kind of destabilizing event is very important. And again, in geriatric oncology, it's now easier, especially easier in the older age, just because here there is a higher threshold. So the event needs a lower threshold to actually destabilize the patients. How will we deal with that in the adult and early life? Well, this is the hope that longevity medicine will help us. And as you can see here, we have also quite a good base of knowledge that response to pharmacologics will be different in those patients, but the same is true for younger patients. For younger patients that might have some sort of problems in the mechanisms or have a different pharmacogenomics or any other points that we actually don't check for before we start the therapy. There is a standard and we go after it. If that's the best way, most surely not. How can we optimize it? That's the point that we are working on in ger-oncology. And here I would just like to make a point that is also important. Surgery, chemotherapy, radiotherapy, in many studies we've seen that actually depriving older patients from the golden standard that is used in younger patients is actually not beneficial for them at all. And many studies have shown that surgery was just as efficient and didn't lead to more toxicities than in younger patients in various types of surgical advancement. And the same was true for chemotherapy. However, in chemotherapy, almost all of the papers that were written on it were pointing out that for many patients it was very important to ask if they prefer the quantity of life, survival, or the quality of life, because most of the chemotherapies came with some sort of toxicities. But in general, in the trials, very often for many of the chemotherapies, there were no difference in toxicities for older patients. And for those who got even the newer types of therapies, so targeted therapies, immunotherapies, and so on, those differences were even lower. So it is important to remember that chronological age is definitely not a good surrogate for decision-making in terms of diagnostics and therapies. And as I mentioned, these are some of the examples of the societies that are working on geriatric points. Now, what we have done is we've screened our geriatric population, for example, here in the hospital of Basel at the time, across all the diagnosis, all the stages of solid tumors. And then we try to implement screening tools. We implemented GI screening tool and mini COG for dementia and for the physical part. And we also asked the people that we were working with, so you can see here across different healthcare professionals. We had therapists, nutritionists, and physiotherapists and others, psycho-oncologists, if they have any experience working with elderly patients. And most of them actually did, because most of our patients in oncology are elderly. And that helped us to even build up a first study, GAIN study, that was presented at ASCO in 2020, where we just trained the screening tools in that population and see if it led to a better outcome. It definitely did. The secondary outpoints were not statistically significant, but that's because of the population size. But most of the outcomes, and especially the toxicities and the returns for follow-up in oncological sessions, they went up. ER and presentations and hospitalizations went down. So very good points that we were able to make. This led to implementation of newer scores, just to mention here the CRUSH and the CARC score. They are very well established in oncology, and also other scores that are being used in some of the research studies because they are quite time consuming. So finally, there is an internal academic guideline for our physicians on how to deal with the geriatric patients, and it's very helpful. But now we try to put it into the ger-oncology, right? So here you can see that we would biologically test every patient for the biological age. So every cancer patient who is coming for the first presentation, we would run a set of biological aging clocks. Now, well knowing that they are not adjusted for cancer patients, we are trying now to get a proper data set actually to develop one. And then we would go through exactly the same strategic rational thinking. Are they, by the screening tools, rather to be assessed biologically older, so more potential, more vulnerable to frailty or not, and guide them accordingly in the triage. That has developed further in the research setting. My last two slides, Morten. In the setting in the clinic, we also implement now further longevity diagnostics, functional, and so on, and also apps and digitalizations, and that also led to an e-health project. And last year, we actually also had a first conference on ger-oncology. It was a Sino-Swiss conference, extremely biased because I'm in Switzerland and in China, so we had this ger-oncological setting. First for the GI tumors. Why? Because we have most and best solid data in this type of in this type of tumor, so GI, stomach, and colon cancer, in terms of very good biopsy points. But what I would still like to mention, if I may, is a study that we just did recently in the pancreatic cancer setting. Here we go. So pancreatic cancer has a very poor overall survival, and we have the biggest cohort of about 10,000 patients for the follow-up for the past 10 years. The survival data are still ongoing, so I cannot show the correlation of the biological age delta change before and after the surgery/chemotherapy, but most probably it has a surrogate and is associated with a poor prognosis. But at least what you can see here, definitely we see a change of the biological age before and after the surgery, and that is correlated to more toxicities and a shorter disease-free survival, so shorter time until recurrence occurs, and that biological age delta is more expressed in males. So something that we see also in other studies and in other disciplines, males seem to be more vulnerable towards this type of shift and change. And with this, I would like to end, and thank you so much for your attention. No questions?
Thank you so much, Eva. We have maybe time for one very quick question. Very quick question. Does anybody have a very quick question?
Thanks, very nice talk. So many cancer survivors now show symptoms of premature aging, especially survivors of childhood cancer. So is that something that is considered in ger-oncology? Because I think it's getting a more and more serious problem because there are so many survivors, no?
Right. So actually there are very good studies in breast cancer, because breast cancer, you know, especially the early stages, have a very good survival. And thanks to the AI, actually, we you know, many groups, especially in China, were able to pull a lot of data. So it is a part of definitely ger-oncology and longevity medicine, because you have this longer survival in the patients, right? And a very interesting correlations are shown, especially in this cohort, between cancers like triple-negative breast cancer, very poor overall survival, versus regular lobular breast cancer. And I think from that conclusions, we will be able also to have testing that will allow us to triage the patient there. So it's really mostly about how you treat, how you decide the treatment based on that.
Treatment,
Yes, exactly. Thank you so much.